Oh, good morning, good afternoon, good evening. We're delighted to be with you here on the session on gender gaps in digital health, why and how do they matter for future health systems. We're very excited to get started, and I am going to give you, let me introduce myself, and then I'll give you an overview of the session. So I'm a professor at the School of Public Health at the University of the Western Cape. I'm Indian, but I'm very privileged to have moved here 4 years ago to work in South Africa at this university. I'm a qualitative researcher who's been working on gender and health systems, amongst other things, for some time. I'm delighted that you can join us in this conversation. And I'm going to give you an overview. Many of you will have hopefully joined the symposium sessions, so are not novices to how this works. But the next slide, let me just give you a few pointers very quickly on how the platform works. So the next slide, you will have been familiar. If you ever have problems accessing the presentation or hearing speakers or anything, there's a live support function. Please, we're going to keep track of the Q&A session. Although many of you you can see us, but you can't see the other participants. A key way to engage is the Q&A session and the discussion forum. In the Q&A session, please just put questions there and vote questions that you think are the most important. We'll be tracking that. But if you have comments, experiences, reflections, resources to share, put them in the discussion forum. Okay, that'll be a great way. And introduce yourself in the discussion forum. That's a great way to get to know each other. You have a better experience if you have this on full screen, and it helps. There's just some pointers on adjusting your Zoom ratio to see everything much better. And to keep in mind, in case something happens and you have to step out, all the sessions are recorded, so you'll be able to hear us again after this. The next slide, let me give you an overview, and I am going to start the first two quiz questions just to get a sense of who is in your room, in the room. And let me just, the results. I assume that people can see. Great. So this is the overview for the session for today. We are going to try and make this as interactive as possible. I'm going to do a brief introduction, and then we have streamlined our session so that you only have 3 presentations, which are hard-hitting and packed with a lot of information. We'll have time for Q&A afterwards. We're very conscious that there are many sessions going on. People have been on Zoom webinars a lot this year and in the symposium, so we're hoping to keep it snappy and engaging. So please do, we have quiz questions throughout the session, so be alert to those. And please, as I said, put your questions in the Q&A, and please share resources, reflections in the discussion forum. So as people join us, I'm just seeing as who's in the room. We have, it's great to have some men in the room. Usually any session that starts with gender scares all the men off, and I'm really glad we have at least a third of the are male. We'll see if they stay with us through the session. I hope so. And in terms of background expertise, we have a lot of people with experience in health systems, some on gender, but very much less on digital health. So I hope the session will be informative and of interest to you. So let me just say a few pointers before I introduce the next speaker on a little bit about how my own impressions of this topic. When I did my master's 20 years ago, my thesis examined technologies in public health from a feminist lens. And my advisor, Sheila Jasanoff, she's a leading thinker in science and technology studies, had said technologies are social and political. because they're developed and used by people who are social and political beings. Today, digital technologies offer so much promise, and they give us the promise to leapfrog towards progress. And Melinda Gates has been a huge champion for digital technologies as a medium or modality to empower women. But how much do we really know about digital technologies, and how do they interact with gender dynamics in health? I was struck by a review some time ago by Larissa Jennings that actually pointed out the evidence at the time was very, there were many methodological flaws, and we make many assumptions about how technology will empower women. And this has led to there's a whole canvas of work to be done to test our assumptions and to dig deeper into understanding better really how do digital technologies, how can they be best used to advance women's health and gender equality? In the last symposium, several of us were part of a IDRC supplement that talked about equity and digital health. And I'm just so excited to be part of this session with colleagues who are from all over the globe, but who are working in India, really diving deeper on this issue of gender gaps in phone ownership. What does phone ownership mean in terms of unpacking that further, in terms of access and use, and also looking forward to the future. What are some key initial findings on engaging on gender dynamics in social media? So I'm going to introduce the next speaker, but as I introduce him, I'm kicking off with the next poll, which speaks to his presentation. So the next speaker is Dr. Diwakar Mohan. He's an assistant scientist at Hopkins. He's a brilliant epidemiologist, biostatistician, and health systems researcher who's been working with us in India on these issues. And he's going to give us a presentation giving us an overview of gender gaps in phone ownership, the magnitude and drivers. And I'm just going to share the results of the poll. You should be able to see them. I don't know, Diwakar, can you see the poll results? Over to you, Diwakar.
Thank you for that very kind introduction, Asha. It is a pleasure to be here to discuss this very important topic of digital gender gap. I would like to begin by defining what this concept of a digital gender gap is. This is the gap that exists when women in the reproductive age group do not have the same access to digital services at the same levels as men or other members in their household do. Mobile phones are the most basic of digital services, and they form the backbone of many mHealth programs. The implication of this gap is that the target population for many such programs using mobile health solutions, especially in the RMNCH domain, needs to be calibrated down from estimates based on household ownership of mobile phones. I want to use this opportunity to drive home three very important messages. The first is that the magnitude of the gender gap in mobile phone ownership can be quite substantial and vary across settings. The second is that this gap is also influenced by many social determinants and is greater among the most marginalized of women. The last key message is that the phone access is associated significantly with greater adoption of some health behaviors, but not others. So basically it means some of them improve but not all of them. Next. For the purposes of my presentation, I'm going to be drawing upon three data sources. The demographic and health surveys from across 15 countries in sub-Saharan Africa and Asia, the most recent National Family Health Survey from India, and the Mobile Gender Gap Report from GSMA. These findings have been published and the references are provided on the slide. Next. The first key message. The digital gender gap can be substantial and variable. Many of you had responded to our poll on the average magnitude of the gap between men and women and phone access. The average ranges from about 5 to 15%. The DHS coverage data shows 13% across 15 different countries, and the GSMA data shows 8% across 10 countries. We had asked which region had the highest gap, and many of you had responded with South Asia, where it is as large as 23%. Next. This graphic from GSMA highlights the wide variation in the gap across the world. The figures in gray indicate the prevalence of mobile phone ownership for women, while the purple highlights the gender gap that exists in these regions. The figure in blue shows the number of women who are still unconnected. We can see that almost 400 million women are reported not to have access to a mobile phone, with almost half of them from the South Asian region. What is not evident from this graphic is that there is a lot of variation across countries within the same region as well. Next. The digital gender gap that we quantified previously is also affected by many social determinants. These include wealth, education, social groupings, urban-rural residents, etc. The net result is that this gap is greater among the most marginalized. I'd like to illustrate this point using data from the Indian survey. Here, you see the rates of mobile phone ownership by households and the women's reported access. The pink dots are the household ownership levels, and the blue dots represent the women's access to phones. As you can see, there is a wide subnational variation among the different states. The gap, represented by the length of the line segment, is on average smaller among the urban population of the states compared to the rural population. The rural gap is as large as 60% in some states, and 40% is the gap in urban areas. Madhya Pradesh, which we will highlight in the rest of the presentation, has high rural and urban disparities. Next. Carrying on along the same lines, the figures show disparity among the different levels of education and wealth across India. The richest and most educated have the smallest gaps in mobile phone access. A point to note is that there is still a 20 to 25% gap among the highest strata of society. Why does this matter? This matters because digital health programs have the potential to introduce inequities and exacerbate existing ones due to selection bias created by who has access to a phone. Next. Phone access is associated with higher adoption of some health behaviors, but not all. Next. This figure graphically illustrates the odds ratio, or the likelihood of the outcome of selected indicators in the maternal-child continuum. The broken vertical line in the middle is a null point or 1. To the right of it are those with a higher likelihood among those with phone access, while those to the left are less likely to be seen among those with phone access. As you can see clearly, key indicators of contact coverage like postnatal care, antenatal care, and skilled birth attendance are higher among those with phone access, along with key immunization indicators necessary for child survival. Only the breastfeeding indicators, which are known to be higher among the poor, do not appear to be influenced by phone access. So this poses a question. Does phone access by itself influence these indicators, or is this merely a result of who can afford a phone? Evidence from decomposition analysis, that's not shown here, suggests that while certain indicators like skilled birth attendance are more about who can afford a phone, other indicators like immunization appear to be influenced by the availability of access to a phone. Next. To conclude, it is important to understand the implications of this digital gender gap. The gap is worsened by social determinants which can also influence health. The access to phones is more likely to impact interventions delivered by community-based health workers in RMNCH, including immunization and care of pregnant and postpartum women. Unless we take into account this gap while planning, digital health programs have the potential to exacerbate inequities. Thank you for this opportunity. Back to you, Asha.
Thank you so much, Diwakar, giving us that overview at a global level, what the gender gap is, but also pinpointing which are the regions that it varies quite a lot by country and by region. And I was struck that many of the participants identified the Middle East as being the region where the gender gap is the widest in terms of digital health. And it is in fact South Asia. So I think it's entirely appropriate that we're diving down into India, and very helpful to also see how much it varies in India across the states and what are the implications. So it matters. Someone has already posted a question asking, how does digital health matter? It matters for clearly some health conditions more than others. So we really need to test our assumptions, as I said earlier. And your implications slide highlighted it matters for a lot of primary and outreach services, but it might have less impact for other types of health services and might be quite a challenge. There are behavioral health conditions like breastfeeding that might not move just with a magic bullet like this. So very helpful to have more nuance in the conversation. We're going to dive down a little bit deeper with our next presentation, and I'm going to release 2 more polls related to that for you to consider. And even if you don't know India, just take a guess. We already told you that some of the largest gender digital gaps are from this region. So I've released the poll, and I'm going to share results. You can see it over time. Please go ahead. 2 people have voted. We're looking forward to all your responses. The speakers here you have a double act. It will be Amnesty Lefebvre from South Africa and Carrie Scott from Canada, but both of them have been working in India on this evaluation. Amnesty specializes in evaluation of large-scale digital health programs, and Carrie has been working with her on the qualitative component. And it's very exciting to have both quant and qual combined together. They're going to take us through, Diwakar sort of spoke about aggregate figures of do women have access to phones and how that affects health. Here we're going to unpack, what do we mean when women have access to phones? So over to, I don't know who starts. Is it Carrie or Amnesty?
I think I'm starting, but I'll shortly hand it over to Carrie to rescue me. So thank you very much. Yeah, go ahead, sorry, Asha.
Thank you. I was going to say we should keep both your videos on. Thank you.
Okay, I think my video is on, but I'm sharing screen so I can't see. Great. Okay, so thank you so much to everybody that's taken time out of your busy days and out of the many competing sessions to attend today. It's my pleasure to be here with Carrie, Diwakar, Sarah, and Asha to be speaking with you today. And we wanted to start our presentation with a broader thanks to the Gates Foundation for supporting the work that we're going to present today, to our collaborators at BBC Media Action and Oxford Policy Management in India, and to the women and their families in Madhya Pradesh who generously gave of their time and perspectives. We'll start our presentation today by presenting a conceptual framework which aims to outline the key determinants of phone access and use. We've sought to apply this framework to a case study in the rural Indian state of Madhya Pradesh, which is home to roughly 20% of India's population. As part of the efforts to apply this framework, we'll draw from quantitative and qualitative research methodologies to make 4 key points. The first is that men have access to higher quality phones with more features than women. Second, women are able to perform far fewer tasks on the phone than men. Third, ingrained social norms limit women's actual and desired use of phones. And lastly, women's types of phone use are more limited than men. In reflecting on these points, we hope to catalyze discourse on the importance of understanding determinants of women's access and use of phones and their implications, not only for health systems, but specifically for future digital health programs. Before we ask Carrie to come in and present our overarching conceptual framework, we first wanted to take a step back and outline the sources for data, which you'll see in the slides to come. As part of a 3-year evaluation of Kilkari, which is one of the world's largest maternal messaging programs and one of the Ministry of Health and Family Welfare's flagship health programs, we conducted a household listing across 4 districts in Madhya Pradesh. This led to the identification of just over 20,000 pregnant women, roughly half of whom did not have access to a phone. Amongst the 50% that did have access to a phone, we administered a quantitative survey, and amongst a further subsample, conducted qualitative interviews. We sought to depict the case study sample in this pyramid visible on your screen to underscore the likely differentials in sociodemographic characteristics between those quite literally at the base of the pyramid, unable to access a phone, and those at the top with access. Let's now shift over to Carrie, who'll help us understand the determinants of phone access and use.
Thanks, Amnesty. Our team, and a particular acknowledgement to colleagues Osama Umar and Ashika Shinde, who are on the qualitative team, along with the larger group, developed a framework to better understand the multifaceted aspect of gender gaps in phone access and use. So this framework, and we hope you will look at it considering your own context and its relevance there, it identifies 5 immediate or proximate determinants of women's phone use. And that you can see as access to the handset, the phone's characteristics and functionality, the woman's digital skill, permitted and desired use, and time allocation. These determinants are embedded in a set of secondary or distal determinants at the level of the woman, the household, and the broader context. Next slide. So key determinants of phone use within the woman are her sociodemographic characteristics, such as her age and her level of education. She'll also have her own unique set of individual attributes that affect her engagement with the phone, so her empowerment and things like her self-efficacy. All of these attributes exist within the household context. For our women in Madhya Pradesh, this is the household she married into. Women may be in their natal home or in a different home. The family's wealth, for instance, will influence the number and types of phones that they can afford and the amount of financial recharge that they put on the phone. Phone needs and allocation will also be influenced by which family members work outside the home and if the phone is needed to coordinate this work in any way. Also, it will be influenced by migration for work, which takes a family member away from the unit and may need a phone to keep in touch. And whether the woman lives in that nuclear family or a joint family arrangement, and the relational dynamics at her parents' home and at her marital home will all influence phone access and use. Finally, the broader context, we have cellular networks, electricity, and market considerations, such as the types of phone plans that add a further layer of secondary determinants of phone use. And of course, undercutting all levels of the framework are the gender norms and attitudes towards women's phone use. We'll now go through the 5 immediate determinants and explain how they manifested in our case study. And remember, that's with the top of that pyramid of the 50% of pregnant women who had access to a phone. Access to the handset relates to whether the woman has a phone and whether she owns a phone or uses somebody else's phone, and how often the phone is close to her throughout the day. In India, among women who said they had access, far fewer of them actually owned a phone compared to their husbands, a gap of 19%. Women depended on their husbands or sometimes their brothers to buy them phones as gifts. And here we have a quote where the interviewer asks who bought the phone, and the woman says, "My husband, who else will buy a phone?" Even when women owned phones, if their husband's phone broke, he would often have to take her phone until he got a new one or until he got his phone fixed. This was sometimes explained because he needed the phone for work, whereas only a quarter of the women were working outside the home. Women also discussed that their phone was often in a common space while they moved around the compound doing chores, which made it quite easy for them to miss calls or for other family members to be using the phone instead of them, whereas the men tended to keep the phone often in a pocket on their body. Among women who shared phones, It turned out that what we called sharing was really borrowing. They borrowed their husband's phone. And that meant they only had access in the mornings and in the evenings when he was home from work and around the house. All of these gender differentials in access to the handset were grounded in norms of low financial autonomy, subservience, and domesticity, particularly around fewer women working for pay outside the home and controlling money. Amnesty, over to you.
Thank you, Carrie. In this slide, we've moved along the framework to explore the second proximal determinant of phone characteristics and functionality. Phone characteristics might include the type of and features available on a phone, as well as available credit. For functionality, while there are a range of ways of assessing this, in India, we've explored this by looking at whether the phones can hold a charge, whether their touchscreens or keypads work as intended, and whether the screen is cracked so severely as to impede visibility. From our case study findings, we found that husbands generally had higher quality phones. This included not only a greater proportion of smartphone ownership among men as compared to women, but as well men having more features on their phones. A further critical factor to enabling phone use is whether or not there's available credit on the phone. This is particularly relevant in contexts like India, where most of the population relies on what are called prepaid packs versus plans which may be more familiar to a North American audience, which allow you to pay the bill at the end of the month. Nearly 90% of women in our sample reported relying on men to top up or recharge their phones and thus add credit to enable use. This finding was additionally echoed in the qualitative findings, some of which are depicted here on the screen, where husbands reported that as the primary earners, they would assume the responsibility of adding credit. In India and in many low resource settings, increasingly phones without available credit or zero balance periods, as we've sort of noted here on the slide, are unable to even receive incoming calls, essentially rendering them useless. Perhaps not surprisingly, this becomes yet one more way in which men become gatekeepers towards use of mobile phones. Overall, the observed and reported gender gaps in phone characteristics and functionality were underpinned again by social norms around women's low financial and physical autonomy and subservience to men. Let's now shift to the next determinant of digital skills. We've conceptualized differentials in men and women's digital skills based on the gaps in their observed ability to perform 5 basic tasks. First, can they navigate voice response prompts? So that might be something like press 1 to speak to a nurse, 2 to speak to a doctor. Second, whether they save contacts actually on the phone or whether they write them on a separate piece of paper. Third, whether they can give a missed call, and then whether they can open an SMS and then open and read an SMS. From these 5 basic tasks, we've additionally generated an overall composite score, which is essentially the average of one's ability to perform all 5 tasks. In our Q&A, it might be worth revisiting why we've selected these basic skills, but I would simply note here that men and women were asked to perform these tasks on their mobile phone device, and as such, the tasks were designed to be device agnostic and able to be performed amongst thousands of beneficiaries as part of large household surveys. What we can see from the horizontal blue bars is that overall women were able to perform far fewer tasks on a mobile phone than their husbands. If we look at the overall score just at the bottom of your screen, you'll see that we see a gender gap of nearly 30%, which is largely driven by differentials in their ability to open and read a text message, a gap of also about 30%. Carrie will now tell us more about qualitative findings on differential skills between men and women. Carrie?
Thanks, Amnesty. And I noticed from the quiz answers there that people actually tended to underestimate how many women could open the SMS, but were quite correct on the percentage of men. So it was 60% of the women could open and 90% of the men could open. But the real drop-off comes when you look at reading the SMS. And that links to the next point, which is that illiteracy among women was a huge barrier to their general digital skills. Inability to read and write and low numeracy as well closed off some phone functions. And here we have a woman saying, the interviewer asked her, what all do you know how to do in the phone? Can you use it? And the woman says, I haven't studied, sister, so how can I? We also noticed that women were discouraged from learning how to use newer phones. So here we have a woman explaining her husband, who has a new smartphone, she says, he does not give it to me, and I do not even feel like learning to use it. If I do, I will get interested in it. Next slide. Looking at permitted and desired use, this is about what the family and society thinks is appropriate and suitable for use and what the woman herself wants to do. we found very narrow permitted use. Women were to use the phone to speak to their families and to keep in touch with their husbands. That was permitted use. And we also found that women themselves had similarly limited desire. They were not saying they were interested in using the phone for social media or for, communication for work or for keeping in touch with friends. In fact, they were clear that they didn't have friends and they wouldn't be keeping in touch with anybody but their husband and their family. And here's a quote where the woman says, "Who else would I talk to? Just Ma and Papa." And we noted that men's permission was reportedly needed to perform even basic tasks on the phone. And these were grounded in norms around domesticity, relationship maintenance, and purity. Over to you, Amnesty.
Thank you, Carrie. Great. So for our last proximal determinant, we reflect on the importance of time availability and allocation for enabling phone access and use. Specifically, this determinant considers questions such as whether women have time to spend on the phone, and perhaps most importantly, whether they can be seen to be using the phone within their family, household, and community context. Our case study findings suggest that overall women spend less time on the phone than men. You'll see from the horizontal bars depicted at the top of the figure that the proportion of women reportedly using the phone on a daily basis was nearly 20% lower than that of their husbands. Beyond the time spent on the phone, we asked both men and women about types of use. Overall types of use were much more limited for women, as depicted in the figure. Fewer women than men used the mobile internet or camera, listened to the radio or pre-recorded messages, or used SMS to communicate with health workers as compared to their husbands. Let's turn back to Carrie to hear more about the qualitative research.
Yeah, so when we dug into this time allocation issue, initially respondents, women and their family members alike, were saying, oh, women are just very busy. They have heavy domestic responsibilities, so they don't have time to use the phone, which is true. However, when we spoke more deeply to them, it really appeared that spending less time on the phone was actually linked to social norms that made women vulnerable to negative judgment if they were seen spending a lot of time looking at or speaking on the phone. These norms were around domesticity and subservience, where she should be seen to be working in the home and does not want to be accused of shirking domestic responsibility, but even more so around norms of purity, which made women very careful not to be seen to do anything that raises questions of infidelity. And here's a quote from a husband saying, if a woman were to spend a lot of time on the phone, they might think she uses it for spurious purposes, that she engages with bad persons, that she indulges in obscene talks. Thanks. Amnesty.
Thanks, Carrie. So in our closing slide, we wanted to reflect on the implications of our discussion today, or the start of our discussion. Overall, we sought to present a framework which captures the relationship between a range of proximal and distal determinants. As we've seen, the factors underpinning access and use are complex, multifaceted, and likely to vary by context. However, access and use constraints have limitations for who programs are reaching and missing. This underscores the need to develop concurrent strategies to reach out to those without access to phones, who are likely to be the most marginalized and disadvantaged, and quite literally at the base of the pyramid, which we started our presentation with. Unfortunately, because of how we've chosen to focus on a sample of respondents with access to phones, theirs is the voice that we're missing. Amongst those with access to a phone, we need to understand access and use profiles and the associated implications for designing initiatives appropriate for those beneficiary populations, likely to optimize technology use for health. From Dr. Mohan's talk, we saw global and India-specific trends in women's access to phones as compared to men's. Much of women's access is shared, and as such, we need to understand what the implications of this are on programs design, and in particular for data privacy. Lastly, we've only superficially touched on this today, but you'll have seen in our presentations mention of different metrics used to measure a range of outcomes. Overall, there's a need to attain consensus on metrics and approaches for assessing access to and use of mobile phones using both qualitative and quantitative methodologies. I'll close for now, but we look forward to continued discussions. Over to you, Asha. Thank you.
Thank you. So that is just an amazing presentation. Sorry, I'm just starting my video. Okay. Thank you so much. That was just a fabulous presentation not just showing further in-depth information. So now I hope whenever someone asks, does a woman have access to a phone, that is only just scraping the surface of, we need to find out much more. What type of phone? How does she use the phone? Does she have time? What kinds of permission does she require? There's so many, if you want to understand the gender dynamics, there's so many other dimensions of understanding access and use. And I really loved the way in which you had the numbers that were very stark, but also the qualitative quotes where women's voices came forward in terms of how they see mobile phones. So it's great that we have more people joining us in the session. As I mentioned earlier, we have questions for each session. I'm going to release the quiz session questions for the next session. And could I please ask if you have comments, please put them in the discussion forum. There have been some very interesting reflections, experiences from Bangladesh and other contexts of challenges in reaching to women. And if you have questions, and I would encourage you to put more questions that might come to your mind as you listen to these presentations in the question box, and vote for your favorite question, okay? So I'm just going to start the next quiz. Sorry, I should have done that already while I was talking. The next presenter is going to be talking about the previous presentations, talked about sort of your presentations on how do we use mobile phones primarily, and how do we link them to improved health outcomes, and what are the limitations of that. Sarah, who is the digital director for BBC Media Action in India, with over 14 years of being based in India and working on these issues, is going to share with us some initial findings of the next frontier. How are women and what are the gender, how are women engaging with social media, and what are the gender dynamics involved? We can't wait to hear. So over to you, Sarah, and let me share the results. People have been responding to the poll. Here we go. You should be able to see.
Yes, I can. Can you hear me?
Yes, thank you.
Okay, great. So thank you so much, Asha, and hello, everyone. Before I let you know which of those quiz answers was correct, I'm going to tell you a little bit about what I'm going to be presenting. So I've spent the last decade immersed in the world that Amnesty and Carrie just presented to you. But now I'm going to present something very different. These are the emerging results of a social media literature review that BBC Media Action is conducting to support the Bill and Melinda Gates Foundation in designing its digital strategy in India. So before I get to that though, quickly to the results. Which of the following social media platforms had the lowest percentage of women users in India? Guys, I'm not able to see any of the responses from the participants in the room. So Asha, you might have to help me out with this.
So people have answered that the oh, it's changing. Now it's a neck and neck race between, okay, it seems like Twitter is the lead platform, followed by TikTok, trailed by Snapchat, Instagram, and 0 on Facebook. Yes, Twitter is winning the game amongst the people in the room, followed by TikTok. So over to you for the answer.
So the correct answer is actually TikTok. TikTok has the lowest, the least number of users who are women in India. And it had 9.5% of its users were women. This is before TikTok was banned by the Indian government because of national security concerns. Okay, so Asha, if we can go to the next slide, please. So today I'm going to present, as I said, data and insights on women's engagement with social media in India and the implications for digital interventions to improve health outcomes. I'll endeavor to answer these questions, the following questions. First of all, is the digital revolution in India male? And in India, does women's engagement with social media platforms differ from men's? What role do online gender norms play in shaping women's engagement with social media? What are the characteristics of female social media influencers? And what are the implications of this for digital interventions to improve health outcomes? The data and insights that I'm going to present come from many sources, which are indicated in footnotes on each slide. However, it's really important to note that there's very little disaggregated data on social media usage in India, and I imagine in other countries, and additional research is urgently required. Okay, so next slide, please. So according to the GSMA, before COVID-19, India was set to become a smartphone superpower, second only to China by 2025, with 1.1 billion smartphones. But only an estimated 9% of all women in the country use social media, which is such a paradox. Smartphone superpower, 1.1 billion smartphones, only 9% of women using social media. This makes sense in a context where only 14% of adult women in India own smartphones in Q1 of 2020, and only 21% had ever used the mobile internet, which begs the question, as I said, is the digital revolution in India male? As you can see from this slide, men dominate social media platforms in India. Literature indicates that social media use increased with wealth and education, and urban and younger internet users are more likely to use social media. Many social media platforms have been criticized for being elite. Although prior to the ban of TikTok, the majority of Indian users came from small cities, and 52% earned less than $330 a month. But TikTok really is the exception. And there have been reports of online clashes between wealthier, higher caste male YouTube users and lower caste, lower income men on TikTok. Okay, I think another quiz should have been released. Is that correct, Asha? Yes, here we go. So what percentage of women internet users in India have experienced online aggression, i.e. trolling, bullying, abuse, or harassment? Big question.
So the response by participants is most participants think it is 50%. And then, so just under a half, say 46% of participants say it's 50%. And then that's followed by about a third, 35% of the participants in this session think it's 90%. And then there are a few here and there, but most people think it's 50, and then a few people think it's 90.
So most people have guessed correctly. A staggering 58% of women who use the internet in India, and remember this is only 9% of Indian use social media, but 58% of those women who do use the internet have faced some form of online aggression, which is a pretty staggering percentage. Next slide, please, Asha. As you can see from this slide, women's use of social media platforms and chat apps in India differ radically from men's. Women, unlike men, mainly use social media platforms to maintain existing networks and communities behind digitally closed doors, rather than venturing into public spaces to build new ones. Now, This is really important because it has implications for any interventions that are seeking to leverage social media to support women in building social capital, i.e. in expanding their networks. So why do we think that women keep their heads down on social media platforms in India? The results of our last quiz, I think, give you a pretty good indication of why women prefer to stick in these closed groups and essentially, keep the door shut to the World Wide Web, precisely because of the aggression and abuse that they face online. Next slide, please. Unfortunately, in India, offline gender norms are perpetuated and even amplified online. Women from marginalized communities face higher levels of violence on social media platforms and in WhatsApp groups than, for example, higher caste Hindu women. And many women are afraid to ask for help from parents or relatives because of concerns that their devices might be confiscated. This environment is unfortunately making women cautious of posting content online. And 40% of women who use the internet have reduced their device use or even deleted a social media account because of online aggression. Next slide, please, Asha. Again, now I'm going to give you another paradox. First, we had 1.1 billion smartphone connections, smartphone devices, and India being a smartphone superpower and only 8% of women using social media. Now, the next one is that despite the fact that pretty much everyone who's online or the majority are men, many of the top influencers on social media platforms such as Instagram and TikTok are women, with tens of millions of followers. Most are mainstream celebrities, so women actors, who use social media to build their largely male fan bases and to endorse products. It's quite a commercial exercise. There are some notable exceptions, however. Sanjeet Jain, who's pictured on the right in the green jacket, is a social worker in Delhi. She was paralyzed in a car accident as a child, and she uses Instagram to talk to her 2 million plus followers about mental health issues, domestic violence, women's issues. So there are exceptions to the commercial norm. If you consider feminist influencers in India, such as She the People on Instagram, and you can see their orange graphic there of what's the definition of a good girl. If you don't follow them, they're really worth following. But these feminist influencers have much smaller numbers of followers. So their numbers of followers are in the hundreds of thousands, but they are growing. Others like Jannat Zubair, and you can see her in the red dress there, with 21.3 million followers on Instagram. So that is a lot of followers. She's one of the top Instagram or one of the top social media influencers in India. She may reinforce gender stereotypes of femininity. And if you follow her, you'll see that's, what she's wearing and how she presents herself. But it's again, there's a really interesting paradox going on here, because even though it's mainly about how sort of sexy she is, and she sings a lot of songs, at the same time, she is modeling an alternate female identity, because she's an independent, very confident Muslim woman who has used her social media following to promote hand washing and mask wearing during COVID-19. And you can see the two graphics there on the screen, or the two pictures on the screen. One is her promoting Lifebuoy soap, and the other is promoting masks. And she's also lined up with or affiliated herself with different women's causes on social media. Next slide, please. So what's the relevance of all of this to health? being in India during the pandemic, what I have seen is a rush to digitize. And many development sector actors and governments have been using social media and chat applications, particularly WhatsApp, to distribute critical health information to citizens. Now, the challenge here is that this approach may leave most women behind. In fact, specifically, it will leave 91% of adult women in the country behind. So, as we've seen, gender norms offline, as Carrie and Amnesty discussed, but also online, are one of the key deterrents for women engaging with social media. So investment is required to help women and girls learn how to protect themselves online, because the internet isn't going away. So if we can help women and girls learn how to protect themselves and how to stay safe online, and to develop strategies for coping with this onslaught of online abuse, interventions, if effectively targeted and designed using a pro-poor gender lens with the women that they aim to serve, have powerful potential. And I'm going to leave you with the following story. Asha, if you next slide. So this is a group of leaders of a federation of 2,000 Dalit women in Tamil Nadu. And these are grassroots leaders with low levels of education. They are not privileged, elite, wealthy urban women. And I think this picture really brings to life what I call bottom-up digital activism. So what these women do with their smartphones, every single one of them owns a smartphone, is they are using them to photograph and video failures in public service delivery. And for example, in public health service delivery, they're going into hospitals and they are filming on their phones huge queues, broken equipment, doctors being absent. And then they are sharing those images on social media, including Twitter, to put pressure on local government officials to redress the situation. And I'm really pleased to say that their efforts have been extraordinarily effective. Okay, thank you.
Thank you very much, Sarah. That was so fascinating in terms of thinking to the future of how we think of these different social media platforms that several of us have, that sometimes speak to certain audiences. So I know like WhatsApp groups, I think of my mother who never used a computer is definitely on WhatsApp. And if you think of, some of these platforms could speak very forcefully. And as you've highlighted with COVID-19, how do we get basic health promotion messages out? Again, some of these might be our best advocates, but I really appreciate the caution with which we need better understanding on who are the most powerful influencers, and are they really, how do we work with them to make sure that they advocate the right health information messages? Because COVID-19 has also shown the amount of misinformation that is also floating around social media. So a provocative presentation showing a number of different aspects of the gender dynamics in social media. So we are going to, I see a couple of questions coming in, and we're going to move to a question and answer session. But I think there is also, we had a slide on next steps, Amnesty.
Yeah, I'm coming.
It was meant to be breaking news.
Wait, which one? This one or wait?
Yes, this one. Okay, go to the next one.
Okay.
We wanted to also share with you, this has been a collaboration amongst the team for some time, presenting some initial findings, but also future work, but there are other things in the pipeline. So maybe Amnesty, do you want to present the first three and I'll present the last one?
Sure. Thank you, Asha, and I'll be quick so that we can get over to a discussion. But just to say that there is a larger community of practice for digital health in India that's led by Dr. Rajani Ved, formerly of the National Health Systems Resource Center. And it is inclusive of 100 or so odd individuals from a range of different organizations. And so this collective group of digital health sort of advocates have sort of come together to sort of generate a special supplement that will come out in early next year in BMJ Global Health on digital innovations for community and primary healthcare in India. There's a sub-theme that includes a lot of gender papers. And so we hope you'll stay tuned to that. And I've noted here on the slide a range of co-editors from a number of different organizations who are working with the submission authors to sort of make this come to life. Then in addition, I know we have some colleagues from UNU, including Claudia on the line. With a consortium led by UNU and supported by ourselves at UCT and BBC Media Action and WHO, there's going to be a gender and digital health webinar series, which we hope to launch early next year. An additional digital health evaluation webinar series also in next year. And then over to you, Ash, on the last point, please.
Sure. So there's also several of us contributed. We have a commentary on, I love the title, Avoiding the Road to Nowhere, because so many digital innovations start but don't necessarily reach scale or are sustained over time. And we brought together several researchers, implementers, and policymakers to reflect on what matters to sustain these digital innovations over time. That's going to come out. It's part of a special issue by the Global Policy Journal. It'll come out in hopefully early next year. It's called The Political Origins of Health Inequities, Technology in the Digital Age. So look out for that. And we have now some time for questions and answers. A lot of our presentation, I want to flag, I'm just going to flag a few points in the discussion box, which echo, because I'm not sure our panelists saw them all, but I thought it was very interesting. Zia Sultana reflected that they found that since husbands use the phone, women couldn't provide consent to follow-up calls on family planning services. So these are the daily, realities in which we design a program, but actually issues of consent and follow-up might be tripped up by who actually has the phone. Someone in Bangladesh said, Ifat Rubia Nasir said, in Bangladesh, we found that most females don't know their phone number, so that during this COVID-19 situation, they had to record patients' phone numbers for follow-up, but they realized that whenever they call a female patient, it's the husband or son who picks up the phone. So this very much echoes the findings earlier in the presentation by the panelists. One question was, we very much focused on what are the challenges and the problems, but from your own experience, and Sarah ended with a positive of yes, digital phones can make a difference. And Diwakar had some positive results, but maybe if the panelists could reflect in outlining what are the ways in which digital health can make a difference for women's health and gender equality? Do you have some examples from your research and from your experience working in this area? I don't know who wants to go first.
I could start, Asha, and tell you a little bit about, so Amnesty and Carrie and Dwarkar have all mentioned the evaluation of Kilkari. So Kilkari is a mobile messaging service for mothers that BBC Media Action designed in collaboration with first state government in Bihar, the state of Bihar, almost 10 years ago, and then has gradually been scaled to 13 states in collaboration with the Ministry of Health. And I'm pleased to say that we have managed to reach 10 million subscribers. And that is through using IVR technology. And, you know, given all of the challenges that women
Sorry, Sarah,
have,
say what that is for people. Just say what
okay,
IVR is for people.
So IVR technology is, in fact, it's not a mobile phone technology. It's that really annoying thing where when you dial a number to do your banking or book a cinema ticket or anything that you want to do and you hear a pre-recorded voice and you have to press numbers on your phone, that is IVR. It's a call center technology, actually. But we have used it to essentially make outbound calls to women based on their stage of pregnancy and then their child's age for 72 weeks. So providing time-sensitive, stage-based reproductive, maternal, neonatal, and child health information. And you're looking at the Johns Hopkins and Cape Town evaluation team that have just completed the evaluation of Kilkari. So I might hand over to somebody else to say a little bit about that.
Sure, we can. I can. Yeah, I mean, so it's part of that. I think that evaluation has shown many things, but one of them is that we've seen a positive impact on reversible contraceptive method use amongst women exposed to Kilkari as compared to those not exposed. Seen a slight bump in immunizations and a few other practices, which is quite remarkable, given that it's 72 messages delivered over a span of 72 weeks from pregnancy to sort of 1 year postpartum. So I think, the thing about a program like Kilkari, which is trying to use a voice technology, as Sarah rightly said, is that, given what we saw around the literacy rates in India and the impediments to women using phones for very basic tasks, a program like Kilkari, which was sort of designed in consideration of that context, it still shows that we see sort of positive benefits in terms of the translation to health outcomes, which is perhaps not something you'd see with other types of programs, which, for example, might send health information over SMS and further exacerbate, sort of inequities in the delivery of that information, given what we know about the profile of even women with access to phones. Over to Asha.
Sure. So building on that, someone, Mary Kinney, has put this question. We noted that 50% in of women in Madhya Pradesh, where you did, and you had quite an extensive sample, 50% don't have phones. And then on top of that, even those who have access to phones, you noted all these challenges. Therefore, should we be looking at alternative options? Number one. And number two, what has been the experience of working with men, engaging men through digital health innovations to support women's health and transform gender equality? Do you have any examples of that? Carrie, you want to start?
I'll just start. And first, I think that Mary is pinpointing one larger point, which is that digital is not a magic bullet. Face-to-face communication still matters. The core behavior change communication through other forms still matter. But I think that another point that comes up is, household access to phones is very high. And programs like Kilkari knew that, and they made sure the messages, if the husband picked up the phone, it actually addressed the husband or the wife. They hoped the wife would get it, but when the husband picked up, he actually knew he was a target of those messages too. So recognizing that you can reach households, even if you can't always reach the wife, is meaningful. And making sure your program is appropriate to whoever picks up that phone. And Amnesty, I see you want to go ahead.
Yeah, no, I'm getting excited. So I couldn't even let you finish speaking. But as part of that excitement, what it also occurs to me is that often health services that we speak about in the context of maternal and child health services are targeting women. And I think there's increasing discourse about the need to also engage men in those conversations, given that women are not always the sole power brokers in decision-making around family planning, around even complementary feeding and infant and young child feeding practices. For those, you may need to engage the mother-in-law. So I think, if we talk about points of contact with the health system, often when we talk about points of contact around maternal and child health in terms of face-to-face services, those are it's the assumption is that it's often between a woman and, a healthcare provider. And we do see sort of increased efforts to sort of encourage bringing along men to antenatal care clinics and so forth for face-to-face encounters. But by and large, I would argue that globally, those services differentially target women. And the benefit of something like, a mobile health intervention is that if done appropriately, you can actually include men in those conversations in ways that are non-threatening, done at a time that's convenient to them, given their working status, etc. So I would back to Carrie. I didn't mean to interrupt you totally, but I would just put those considerations on the table as well.
I'll let others come in as well. Thanks.
Thank you.
Yeah.
Sarah?
If I could jump in, yeah, just to second what Amnesty was saying. I mean, our service Kilkari deliberately targets men because they are the key decision makers in the household. And there's a delicate balancing act, between making something, trying to create an emotional connection with the pregnant woman or mother, while talking to her husband at the same time and not kind of alienating either of them. I mean, it took a lot of work to get it right. But a really interesting question about safe digital spaces. And what I wanted to say is that last story that I told you about this federation of Dalit women, of 2,000 Dalit women in Tamil Nadu. It's a rights-based women's collective. What's so extraordinary, I think, about it, but also the opportunity presented by self-help group federations and other forms of women's collectives is the peer-to-peer support that they provide, and the peer-to-peer learning that can happen in that context, and the leadership that group leaders can provide in supporting and helping women in the group learn how to stay safe online. So I think safe digital spaces are about safe spaces for women in the real world. And they're about the collective, and they're about peer-to-peer support and social cohesion and trust. And if you have that in the real world, that can be a great environment in learning how to be safe online.
Thank you. So the question screen is firing up. There's this one on, do you, in your experience, do men, and I know this was, I think it's great that you're doing research that asks men and women, rather than just asking women and assuming that men agree, or asking men and assuming that women. What has been your experience of actually undertaking research of this kind? And I have put the chat, it's quite a long question, but I wonder if either of you have any reflections based on your own research.
Yeah, I mean, one interesting thing that came out of this, we did dyadic analysis where we looked at what the men said and what their wives said separately from each other. And keeping in mind, this is the top of the pyramid, so it's a special population, but the men were very keen to present themselves as sort of liberal and forward-thinking and facilitators of the phone, like, oh, I'll even dial the number for her and hand it to her. And of course she could learn how to do, e-banking, that would be fine. And the women were a little more aware of the limitations and saying that, yeah, but the phone's always with him, like he might say it's fine for me to use it, but it's always on his person. So we were also able to see that she often articulated a higher set of digital skills that like, I can take pictures, I can do this on the phone, I can do that, but the phone that's in my hands most of the time has a broken camera and doesn't have top-up charge, so there's no data, so I can't do a lot of things. So she was able to kind of differentiate that there was this larger amount of capacity that could have been available to her, but the reality of her everyday use is that primarily she just made outgoing calls and picked up incoming calls, and sometimes the call was even dialed for her by somebody else and handed it to her. So she was able to kind of filter down the reality of her use, whereas I felt the men were much more interested in talking about a more expansive view of, yeah, there's no limits here in this family. The woman can do what she wants on the phone.
Quite different perceptions. I want to give a chance to Diwakar, and we're running out of time. We have 4 minutes left. Diwakar, you did all this analysis across DHS surveys. What are your reflections on how to improve measurement of the gender gap, given all that's been presented? What's your experience?
Sure. It's like to be fair to the DHS surveys and all these kind of big, huge surveys, it's very difficult to standardize questions that can reliably and validly measure this across a wide variety of settings, even within the same country. So right now we have very simplistic questions that kind of ask about, do you have access to a phone? And can you read an SMS? And there was somebody who was talking about financial apps for digital protection yesterday. So the DHS also asks them about questions around, do you use use a phone for doing financial transactions? But the point here is that these questions kind of mask what is the level at which different women operate. Like they might be prone to say yes because they did one simple task with somebody else's help at one point in time, but it doesn't go around to kind of get into the nuance of how good is their response to it. But this is a growing field. The DHS is kind of adding questions, and over the next few years, we will see definitely more and more such questions being standardized and added to these surveys, and we'll have better measurements. One last point that I wanted to quickly make is for evaluation of health programs, we need to understand this inequity in who has a phone. So you may be targeting the best of women who already have a phone with your digital health programs and who already have the best health indicators. And you may very likely see no change in the health indicators. So this is something that we need to keep in mind when we think about evaluation of digital health programs as well. Thank you, Asha.
Thank you. I can see the conversation can keep going. There are many appreciative comments in the discussion forum. I just want to thank the panelists for preparing and providing such excellent presentations and responding to questions. And I hope all of you continue the conversation on the things that are coming up by this group and in posing gender questions in all the other gender and innovations sessions in the symposium.
And digital health questions.
Yes. Thank you so much for staying with us, and we look forward to keeping the conversation.
There are a couple of questions at the end. There are a couple of quiz questions at the end.
Yeah, we still have 2 minutes.
Oh, sure. Well, I was so nervous. I had 2 quiz questions at the end to get a sense of what did you learn? How is this useful? And I had a cheeky question at the very end as well to try and keep it. So just a quick sense of your own sense of the information presented. There's so much in this area. I think everyone, the experience of looking at the DHS survey, but the qualitative research, the more you learn, and working with Sarah, with BBC Media Action, it has been an amazing journey. And as you ask one question, you find out one phenomenon. What Diwakar said is that there's a mask, and then you reveal and you go further, and there are other dimensions. So a huge frontier to explore further. And thank you very much for joining us, and to all the panelists again. Enjoy the rest of the symposium.
Thank you.
Bye.